Thank you to the organizing committee for this opportunity to speak with you today on cardiovascular risk in prostate patients undergoing hormonal therapy. My name is Darryl Leong. I'm a cardiologist and director of the cardio-oncology program at McMaster University in Ontario, Canada. Here is my relevant disclosure for this presentation. The objectives of this talk will include discussing the mechanisms and hypotheses underlying the association between hormonal therapy for men with prostate cancer and cardiovascular risk factors. We will be reviewing the impact of androgen deprivation therapy on cardiovascular risk factor profiles, including the effects of novel hormonal treatments and their importance. Finally, we'll review some of the cardiovascular risk assessment tools that are available to help treat these patients. I should point out that we will not be discussing cardiovascular outcomes per se, as this will be the subject of another lecture in this series. Shown in this slide is a summary of cardiovascular risk factors, the key risk factors that influence the development of future cardiovascular disease. On the left, we see that some risk factors, such as increasing age, genetic factors, and family history, are not modifiable. However, in research that we've participated in a large international cohort study of over 100,000 adults from around the world, we find that 70% of the attributable risk of developing cardiovascular disease in the general population is accounted for by the risk factors you see listed here. And many of these will be familiar to you, including hypertension, diabetes, dyslipidemia, smoking, alcohol use when it is heavy or episodic, being overweight or obese, and low physical activity and low muscle strength, as well as low education. These risk factors are highly pertinent to men initiating ADT because, as you will see from this slide and as we will demonstrate during the course of this presentation, many of these risk factors can be influenced by the administration of ADT. I think it's useful and insightful to actually, before heading to discuss ADT, discuss the influence of testosterone on cardiovascular risk factors in the general population. So shown here is a summary of meta-analyses that were undertaken examining the association between each quartile decrease in testosterone in the general population and various cardiovascular risk factors that form part of the metabolic syndrome. As you can see, decrease in testosterone is associated with an increase in obesity, dyslipidemia, hyperglycemia, and therefore diabetes, as well as hypertension, with effect sizes ranging from 24 to 58%. It is also instructive to review the effect of testosterone supplementation in men in the general community with low testosterone levels endogenously. Here is a meta-analysis of randomized controlled trials, including about 5,000 men with low testosterone levels, showing the effect of testosterone replacement in these individuals. We see highlighted in the red boxes that testosterone replacement reduces fat mass but increases lean body mass. It improves fasting glycemia and insulin sensitivity, but has little measurable effect on cholesterol levels and blood pressure. So with this context, we can summarize the effects of testosterone as it appears in the general population in this slide. Low endogenous testosterone levels seem to be associated with increased adiposity, dysglycemia, as well as dyslipidemia, hypertension, and reduced muscle strength, and also with an increased risk of cardiovascular events. While replacing testosterone in those who are deficient in randomized trials does lead to a reduction in adiposity, dysglycemia, and increase in muscle strength with little measurable effect on lipids or hypertension, and its effect on cardiovascular events remains at this stage somewhat uncertain owing to the limitations of the data. So moving on to hormone therapies for prostate cancer, the most common form of androgen deprivation therapy is in the form of the GnRH agonist. And as you know, these agents act on the anterior pituitary gland to cause hormonal changes which are quite distinct from that which is observed among individuals in the general community who have endogenously low testosterone. The GnRH agonists lead to an initial surge in follicle-stimulating hormone, luteinizing hormone, and testosterone before leading to suppression in these hormonal levels, and microsurges in LH and testosterone could be seen on repeat injection. Importantly, while FSH is initially suppressed, this suppression may not be maintained long-term, and some degree of breakthrough may also be seen. This slide summarizes the associations between androgen deprivation therapy use in men with prostate cancer and the risk of cardiovascular risk factors developing. I should note that these are all from observational data, and we'll review some of these data in subsequent slides. But in summary, androgen deprivation therapy is also associated with an increase in adiposity and dysglycemia, as well as triglyceride levels with modest effects, if any, on low-density lipoprotein cholesterol. Hormonal therapy reduces muscle strength and is associated with an increase in cardiovascular events. Here is some seminal data by Dr. Smith, demonstrating the effect of initiating the GnRH agonist leuprolide on 26 men with prostate cancer. What you can see in the square symbols and circular symbols is that over a 12-month period, there is approximately a 3% increase in body weight and waist circumference in these individuals. In the same study, Dr. Smith demonstrated that the administration of the GnRH agonist was associated with an increase in triglyceride levels in the diamond-shaped symbols with little measurable effect on low-density or high-density lipoprotein cholesterol levels. This slide illustrates retrospective data from the United States, including over 12,000 men with localized prostate cancer whose information was recorded in administrative databases. What we can see over long-term follow-up is that those who were administered androgen deprivation therapy in red as primary therapy had a higher risk of developing diabetes during follow-up than those not treated with ADT primarily. And the hazard ratio for this association was 1.61. And shown here is data from Taiwan from 6,000 men studied in a retrospective analysis, where those who had received ADT in the red dots were propensity score matched with patients who never received ADT in the black solid line. Shown on the vertical axis is the time free of new hypertension. And what can be seen is that those exposed to androgen deprivation therapy over the course of some 10 years had a 78% increase in the risk of developing hypertension as compared with those who had never received androgen deprivation therapy. Low muscle strength is an under-recognized but increasingly studied risk factor for adverse cardiovascular events. It can be simply measured using a device such as this, a hand grip dynamometer, to measure the strength of hand grip. And this is correlated closely with the strength of muscles throughout the body. Using this tool in the general population, we have evaluated the association between muscle strength and cardiovascular outcomes. We found that in about 140,000 adults from multiple countries around the world, every 5 kilogram reduction in hand grip strength was associated with a 7% increase in the risk of myocardial infarction, a 9% increase in the risk of stroke, and a 17% increase in the risk of cardiovascular death. This finding is pertinent for men with prostate cancer because in this data by Gonzalez and colleagues, we see the effect of ADT on muscle strength as measured by hand grip. In the dashed line shows the hand grip strength change over 12 months amongst prostate cancer patients managed with prostatectomy, and in the solid black line, the change in hand grip strength amongst those who received androgen deprivation therapy. And we see a clear divergence over time, especially because those receiving ADT have a reduction in muscle strength as a consequence. While GnRH agonists have been in use for many years now for the treatment of advanced prostate cancer, the GnRH antagonists represent a relatively new advance in therapeutic options. Importantly, the antagonists do have some differing effects compared with agonists. As summarized here, we see that the suppression of FSH, LH, and testosterone with the GnRH antagonist is immediate with no microsurges and with more prolonged and even suppression of FSH, LH, and testosterone over time. There have been relatively few head-to-head data comparing the effects of GnRH antagonists with agonists when it comes to cardiovascular risk factors. Here is one relevant study led by Dr. Smith comparing 400 patients receiving Darryl at one of two different doses versus 200 patients who were treated with leuprolide for their prostate cancer. Over a period of 12 months, there were similar degrees of weight increase, increased blood pressure, while the incidence of hypercholesterolemia and diabetes was fairly uncommon during this short-term study. And so it's difficult for us to draw strong inferences about whether or not there are differences between Darryl and leuprolide when it comes to cardiovascular risk factors. A detailed study was undertaken by Sawazaki and colleagues, randomizing 85 men with prostate cancer to the GnRH antagonist Darryl or the GnRH agonist leuprolide. Shown here are the differences between the groups with respect to blood sugar and HbA1c on the left side, and body weight and abdominal circumference as markers of adiposity on the right. And what we observe is that there was no significant difference detectable between Darryl and leuprolide with respect to these outcomes. Shown on this slide is the comparison between the groups when it comes to lipids of various types, including total cholesterol, low density and high density lipoprotein cholesterol, and triglycerides. And again, there was no difference detectable between Darryl and leuprolide. Shown here is data from the recent HERO trial, in which the new oral GnRH antagonist Retrospective was compared head-to-head with leuprolide. As you might know, there was a significant reduction in the occurrence of major adverse cardiovascular events in the Retrospective arm, approximately 50% reduction in such events. And in the main trial paper, only the cardiovascular risk factor of hypertension was reported. In this presentation, the authors reported that 7.9% in the Retrospective group developed hypertension as compared with 11.7% of the leuprolide group. Therefore, I think it is fair to summarize at the present time that we do not have enough evidence to suggest that there is a substantial difference in the incidence of cardiovascular risk factors between GnRH antagonists as a class and GnRH agonists, and more research is needed to clarify and provide more detail in this area. Of course, androgen synthesis inhibitors represent a major advance in the therapeutic options for advanced prostate cancer as well. Shown here is a meta-analysis of randomized controlled trials of the androgen synthesis inhibitor abiraterone with respect to the outcome of hypertension. And what we observe is that there is, on a pooled level, a 46% increase in the use of in the risk of hypertension with abiraterone use as compared with placebo. And notably, this increase in hypertension risk comes on top of that conferred by leuprolide or other GnRH agonists, which patients in this trial were already taking. Shown in this slide is a meta-analysis of randomized controlled trials of the androgen receptor blocker enzalutamide. And what we see here is a more substantial increase in the risk of hypertension, in the order of 2.6-fold increase with the use of enzalutamide as compared with placebo when used on top of androgen deprivation therapy, and in particular GnRH agonists. And shown here is the pooled risk for fluid retention or edema in randomized controlled trials. And this meta-analysis includes both data from abiraterone and enzalutamide randomized controlled trials, demonstrating a 38% increase in the risk of fluid retention and edema with either of these agents. So if we accept that men with prostate cancer, and especially those being treated with hormonal therapy, are likely to experience an increase in their cardiovascular risk, how can we evaluate this in the clinical setting? Cardiologists will frequently implement a risk scoring system, such as the Framingham Risk Score, which requires the collection of data on various parameters, including age, lipid profiles, blood pressure, smoking status, and diabetes. And these will be integrated into calculating a risk score using an algorithm such as this one, where a number of points are allocated for each of the risk factors and their degrees that the patient has. Following this, the risk score can be translated into a predicted 10-year risk of a major adverse cardiovascular event. And we consider a 20% 10-year risk of major adverse cardiovascular events to be fairly high risk, and certainly more than 30% 10-year risk to be quite significantly elevated cardiovascular risk. Using the Framingham risk score, we have evaluated the baseline cardiovascular risk in nearly 2,500 men from multiple centers across Canada with prostate cancer. These individuals had either newly diagnosed prostate cancer, and this accounted for the majority of participants, or there was a plan to treat them with androgen deprivation therapy for the first time. We found that 69%, so over 2/3 of participants, had a Framingham score of 15 or greater, and this score is associated with a 20% 10-year risk of cardiovascular events. And when we use in the figure a more stringent Framingham score threshold of 17, we find that about 1/3 had a very high risk of future cardiovascular events of around 30% over the next 10 years. So if we accept then that men with prostate cancer in general have a high prevalence of cardiovascular risk factors and a high cardiovascular risk profile, what is the best strategy to prevent cardiovascular disease in these individuals? It would seem intuitive that identifying those who are likely to benefit from preventive medical strategies would be advisable. However, we must also acknowledge that many urology clinics may be unaccustomed to evaluating cardiovascular disease risk. On the other hand, the diagnosis with a new prostate cancer may in fact represent a teachable moment when the patient is open to reforming parts of their lifestyle to help improve outcomes in other areas like cardiovascular disease. At the present time, we're conducting a large randomized trial called Radical PC2, in which men with prostate cancer are randomly allocated to receive either usual care or usual care plus the routine referral to a cardiologist or internist who would administer a statin, target a systolic blood pressure of less than 130, and provide routine diet and exercise guidance to patients. To date, over 1,500 participants have been randomized, and we hope that this trial will provide more information about the role of a cardiologist in helping to reduce cardiovascular outcomes and risk in men with prostate cancer. Until that time, however, when we have data from studies such as this, a pragmatic approach to cardiovascular risk assessment and reduction in ADT recipients may involve identifying cardio-oncologists at one's institution. At most tertiary referral centers now, cardio-oncology clinics exist where cardiologists with an interest in patients with cancer practice and see patients. Understanding that capacity will vary according to cardio-oncology practice, communication with cardio-oncologists is likely to be important so that criteria for referral can be agreed upon. And I think it would be prudent that referral criteria be kept simple and straightforward and may include clinical factors that can be easily recorded, such as a history of cardiovascular disease, diabetes, or hypertension. So in conclusion, the data would suggest that many men with prostate cancer have a high burden of cardiovascular risk factors and that androgen deprivation therapy is very likely to worsen these cardiovascular risk factors. Over and above GnRH agonists, agents like abiraterone and enzalutamide may in fact worsen hypertension further and promote fluid retention and potential for edema. And therefore, collaboration with cardio-oncology may help to address these cardiovascular risk factors in men with prostate cancer. So with that, I'd like to thank you very much for your attention, and we will be very happy to take questions during the discussion forum.